Welcome back to the podcast. It's Matt and Joe again doing another turbo dose. Today we're talking about the approach to the breathless patient. We're going to cover again a sort of a structured A to E approach, just giving you guys some standardization of how we like to do this in our practice. Hopefully it'll help you perform well in sim and in practice.
About the breathless patient and looking at airway, first thing that we want to do is obviously check the patency of the airway. Now, hopefully one would recognize there was a significant choking or obstruction. So foreign body airway obstruction, really, really common. If there is a significant foreign body that's causing that shortness of breath, we need to check it. So we actually need to not just think about putting adjuncts in, but we need to actually have a look in the airway, look as to whether there's vomit, whether the patient's regurgitated or not, whether there's food, dentures, etc., and remove those as appropriate. And then if the airway requires manual airway maneuvers, then we would be performing those head tilt, chin lift, jaw thrust. And really we want to be checking for those breath sounds, whether that's through sort of looking, listening and feeling, or whether actually when you apply the oxygen mask, which it should be for all of these patients if they're breathless, looking at sort of misting of the mask. And then start thinking about some of the other presentations within airway that are really important to acknowledge, like angioedema. So we talked about that in a previous podcast, but are you breathless because actually this is a significant anaphylaxis? You've got technically an obstruction in the airway, you've got edema of the tongue, edema of the soft tissues within the mouth, and actually we need to manage that right away, don't we, Matt? We're not going to move on to breathing and circulation before giving that adrenaline. That adrenaline goes in at A to then move on to breathing. What do we want to do? How do you structure that breathing assessment?
So obviously you want to get a SATS probe on pretty early just to see what the oxygen saturation levels are. We're going to check a respiratory rate. Now, respiratory rate is probably the most important observation you can take, the most sensitive marker of acute illness, often performed very badly. So make sure you're counting for an adequate period of time. And then we want to check that there's equal air entry and equal rise and fall of the chest, i.e. both sides. If absent, that's going to suggest presumably a pneumothorax. Auscultation, again, to have a little listen with the chest and a bit of a percussion as well. It's important when you're doing an A to E not to overcomplicate it. So when you're listening to the chest, just listen for crackles, listen for wheeze, listen for air entry or the absence of air entry. Don't try and worry if it's coarse crackles or fine creps or all that sort of stuff. Monophasic wheeze, biphasic, it doesn't matter. Just identify that there is crackles, wheeze, absence of air entry. Looking for a JVP is important as well. Again, is it raised? Is it not raised? That's all you need to know. Don't worry about all the different types of waves you learnt about in the early years. If it's raised, it suggests either fluid overload, so something like heart failure, or can suggest something like raised intrathoracic pressure, again from a pneumothorax. Now, personally, I tend in B, when I'm seeing breathless patients, I tend to look at the calves to see if there's any redness or swelling suggestive of a DVT, or if there's any edema as well. Joe, do you do that, or do you not do that?
It's practice variation, isn't it? And personally for me, I don't do that, and I would leave it to exposure and examination, but I can absolutely see how it would allow you to corroborate, what the cause of a breathless patient is, and then allow you to start some treatment earlier. So I think if you're safe to do it and there's no other immediate intervention, then you can do it in B. It's reasonable as long as we check it at some point.
Yeah, same sort of thing in terms of, so we often we'll talk about getting chest x-rays and arterial blood gases as part of B. The reality is when you're in practice, doing that takes you away from the patient. So I think, again, we'd advocate, yes, it's good to do a chest x-ray, but you can do that at the end of, once you've done that rapid A to E.
So thinking then, Matt, about interventions, what do we do when we find these issues? Shortness of breath causing tachypnea, you auscultate the chest, there's an expiratory wheeze, great. We can start thinking about providing salbutamol, ibupropium, and other such bronchodilators. Shortness of breath and tachypnea, and you find that there's bilateral pulmonary edema, possibly with a history of heart failure, great. We can start thinking about furosemide. So actually that investigation into the chest is the most important part, really, isn't it, in order to allow us to correct what is happening at B. And so it can be a little bit confusing, but it's more about noticing that high respiratory rate and going, right, I need to stop there and figure out what's the cause of that. Quick auscultation, quick percussion, quick feel of the chest will give you pretty much all the information you need to know.
So for circulation then? So again, we're going to have a quick feel of their peripheries. Are they warm? Are they cold? Cap refill time as well, centrally. Heart rate, obviously, and blood pressure as well. getting an early or an urgent 12-lead ECG, because arrhythmias are a common cause of breathlessness, or the sensation of breathlessness. And equally, if you're having an MI, you may well have an MI in the absence of pain. So if you're a diabetic patient, if you're elderly, if you're female, and if you're Afro-Caribbean, these patients generally have presentations less focused on pain, and there's often other things going on. So just have a quick look there at an ECG.
Yeah, no, I completely agree. And I think we really commonly see things like fast AF causing a breathlessness. And then also, Matt, thinking about checking for peripheral edema as a sign of heart failure, and to corroborate again that if you've got a bit of a raised AVP, you've got a bit of those crackles going on. Sometimes you can just have an isolated edema, which might give you an indication that there is a heart failure history going on. It may and may not be necessarily the cause of breathlessness, because it's exceptionally common. Moving on to disability, how do you assess disability and what are the relevant areas within breathlessness, Matt?
If the patient's hypoxic, they might have a slightly reduced GCS. And equally, if they're hypercapnic, so they're slightly narcosed, CO2 narcosed, they can have reduced GCS as well. But really, it's due to the breathing problem. So that's the thing you want to treat rather than considering anything central in the brain. And then finally, make sure you're checking a temperature as well and exposing the patient adequately.
When we're thinking about history, one of the most important things that we want to think about is the onset of this breathlessness and the sort of duration. You don't want to be talking to a chronically breathless COPD patient thinking this is a new breathlessness. A very easy answer to this breathlessness presentation is, are you more breathless than usual, or is this your normal breathlessness? Because you're really surprised at some of the states of our heart failure patients, our chronic disease patients. They look like they're acutely short of breath to us. This could be normal for them. Thinking about onset and duration, if there is a sudden onset of shortness of breath, when you start thinking about things like pulmonary embolism, thinking about anaphylaxis, with a bit of chest pain, thinking about myocardial infarction, thinking about pneumothorax. If it's more gradual, then we can start thinking about our infective signs and symptoms. So your lower respiratory tract infections. You can start thinking about your pulmonary edema. You can get flash pulmonary edema, but more common is your chronic heart failure that can come in and out of exacerbation. And a pleural effusion, those types of fluid buildups are usually chronic and not sudden onset in nature. So think about the onset and duration is really important, because actually you can categorize your differentials based on that. What other things do you think about in history, Matt?
I think severity is important. So are they so short of breath that they can't mobilise? What impact is the shortness of breath having on their activities? That's just important to help you grade it, but to understand almost when they can be discharged. So if a patient is so breathless they can't get out of the chair or mobilise around their home, that's not somebody who's going to cope well if you discharge them. So they're going to need admission until that's fixed. So I think that's highly important. Other things supposed to consider would be sort of the events that led up to the breathlessness. So has there been any recent trauma? Have they possibly fractured a rib and that's causing them to be breathless? Were there any allergens present? If this is a sudden shortness of breath, have they just had some seafood in a sandwich or peanut or something like that? If they're lying flat, so back in the day in ED, you always had a 6 a.m. pulmonary edema pre-alert from the paramedics, because you had patients who had been asleep all night and then woke up really short of breath. And then other things like stressful events, so panic attacks is something it's important to consider. Have they just been going through something highly emotional and then had a bit of a panic attack that's causing them to feel short of breath? I
think you can discuss this by simply just asking a question, can't you? What were you doing at the time, or what events led to you becoming short of breath? Oh, I was in a restaurant eating shellfish. You don't commonly get that slam dunk diagnosis, but they often do give you some really important information. Thinking about associated symptoms, we have sort of woven that through the previous discussion, but associated symptoms, of course, we're going to be talking about chest pain. Respiratory and cardiovascular system go hand in hand. And so is there any chest pain alongside your shortness of breath? We're thinking about pulmonary embolism. We're thinking about pneumothorax. We're thinking about our acute coronary syndromes. Chest pain is, however, difficult because quite frequently in your infective patients, they will have been coughing for a long time, and they very, very often have musculoskeletal chest wall pain and or a bit of costochondritis or something like that. Bit of a red herring. It's quite difficult to tease out the exact cause of that, and that's why history will be used alongside physical examination, bloods, etc., to really get down to the diagnosis there. Is there a cough associated with that shortness of breath? Again, thinking about infection, thinking about edema, and is there a fever? This is really a slam dunk diagnosis. What else do you think about in terms of associated symptoms, Matt? There are a few more categories I guess I could think about.
So hemoptysis. Don't see massively often, to be honest, but again, that's going to point you towards, well, depending on the cause. If it's sudden, that would suggest a PE. If it's more gradual, that might be something like a lung cancer, a neoplasm, or something like that.
And again, it can be a red herring, can it? Because really, lower respiratory tract infections, Mallory-Weiss tears, very, very, very common in that kind of pseudo hemoptysis that we very frequently see. We see these presentations all the time in primary care of chest infection now coughing up blood. So we just need to think and mitigate the risk as to how serious this is.
Collapse is another important one. So if the patient has had a collapse and they're short of breath, we always need to consider PE. It's important, obviously very important not to miss a PE. But other things like arrhythmias as well, which we mentioned earlier, can cause a sensation of breathlessness. And sometimes if you're having an arrhythmia and you lose a bit of that pump function for a little bit, you can have a collapse too.
Quite often you'll ask 100 people if they've lost consciousness before one person will say yes, or if not more. But it's one of those things you don't want to miss. That's all we were going to talk about today in terms of breathlessness. We've gone through the A2E approach, how you would stratify that in order to funnel down your diagnosis and ensure that you get properly treatment to patients who are presenting critically unwell. Then we've just talked about some of the historical findings, thinking about onset, thinking about severity, thinking about precipitating events, and then thinking about associated symptoms. Putting that all together should give you a really well-rounded way in which to manage presentations and then escalate as required.